Good afternoon. On behalf of the Pennsylvania Patient Safety Authority, I'd like to welcome you to this web conference titled Bullying in Healthcare, a Disruptive Force Linked to a Compromised Patient Safety. My name is Rick Andravy, and I'll be your moderator for this program. Today's web conference is 60 minutes, including Q&A, and will be recorded. Now I'd like to introduce our speakers for the webinar. Our first speaker, Susan Wallace, is a patient safety liaison with the Pennsylvania Patient Safety Authority for the South Central region of Pennsylvania. She offers 15 years of experience in risk management, safety analysis, and patient safety. Prior to her present role, she was a patient safety analyst at ECRI Institute, where she analyzed events and wrote articles for the Pennsylvania Patient Safety Advisory. She was also employed in Pennsylvania hospitals as a director of risk management, patient safety officer, and safety analyst. Our second speaker is Kelly Gipson, a project manager with the Pennsylvania Patient Safety Authority. Kelly started with the authority as a patient safety liaison for the South Central region of Pennsylvania. In this role, she has been involved with initiatives to decrease patient harm, such as education, webinar development, consultation, on-site observations, advisory article development, and incorporation of the patient voice into the authority's work. Prior to joining the Patient Safety Authority, she worked as an associate patient safety officer and was involved in many multidisciplinary initiatives to improve safety culture, such as alarm management, root cause analysis, just culture, no-pass zone, and safety event analysis. Our third speaker, Dr. Renee Thompson, CEO of RTConnections, is an international speaker, author, and consultant who tackles the professional challenges facing healthcare leaders today. With 26 years as a clinical nurse, nurse educator, quality manager, and nurse executive, Dr. Thompson is an expert on workplace bullying and spends the majority of her time working with healthcare organizations that want to eliminate bullying and incivility. Dr. Thompson has repeatedly published, interviewed, and awarded for her work to educate, connect, and inspire current, future nurses in healthcare. She is an author of several books and is in demand as a keynote speaker. Susan, now I'll turn the program over to you.
Thank you, Rick. And hello, everyone. I'm really excited to be presenting information with Kelly and Renee about bullying and how it compromises patient safety. Our objectives are to define bullying and recognize these types of behaviors, identify how these behaviors compromise patient safety, and give you some tools and strategies you can use to address and reduce workplace bullying. So what Kelly and I found when researching this topic was that bullying or aggressive behaviors such as verbal abuse and intimidation between healthcare providers can be a threat to safe patient care, and it has increasingly become part of the national dialogue since the Joint Commission recommended adoption of a zero-tolerance policy towards these behaviors. So what we wanted to explore is what is bullying and what does bullying look like in the hospital, in an ambulatory surgical center, and other healthcare facilities, and to be asking yourself, do you feel like you're being bullied? Or, on the other hand, is it possible that you are the bully? So let's start with the definition of bullying. We use the definition from the Workplace Bullying Institute to review events and PACERs. And according to the Institute, bullying means an intended target is being repeatedly mistreated with verbal abuse, threatening, humiliating, or intimidating behaviors, and there's work interference, such as sabotage. And in the article, we had to combine what we were seeing in the PACERS reports with bullying behaviors. So we weren't able to see repeated mistreatments because each event must be associated with a patient to be entered into the PACERS system. We considered bullying as a term that may overlap with incivility, horizontal, lateral, or workplace violence, and unprofessional, disruptive, or disrespectful behavior. So sometimes it seems as though these terms are even used interchangeably, bullying versus incivility or versus horizontal violence. So, Renee, what has your experience been, and what are you seeing in healthcare facilities?
Yes, thank you, Susan. You know, and my experience in working with a lot of leaders and a lot of organizations, I actually find that this is probably the most important definition that they need to understand. You know, we tend to call all behavior that we don't like as bullying. And when we do that, it's a real disservice. And something that maybe the audience doesn't always understand, there are legal definitions for harassment, for discrimination, but there's not a legal definition for bullying. And so as the Workplace Bullying Institute defines, you know, it is the repeated mistreatment of a target. And the definition that I always use is that bullying is the repeated patterns of disruptive behavior with the conscious, that person knows they're doing it, or the unconscious, they're not even aware, attempt to do harm. And so when somebody reaches out to me and they say, I don't know, I think I'm being bullied, I'll say, okay, well, let's talk about this. I'm looking for three things. Number one, for behavior to be considered bullying, there has to be a target. So Susan, let's say you and I work together. And for whatever reason, I don't happen to like you, okay? Well, of course, I do like you, but, you know, if we were working, I don't like you. So when let's say we're staff nurses, when I give you report, I'm really hard on you. I dump on you. When you're giving me report, I will nitpick you to death, okay? I will set you up to fail. I will yell at you, criticize you in front of other people. But I don't treat anybody else that way, okay? It's just you. It can be one person or it can be a small group of people. Here's the classic. I'm the night shift and I hate the day shift, or I'm an experienced nurse and I've been working in this organization for 50 years and I don't like any of you new people coming in. So I target all of the new nurses. So there has to be a target, though. It could be one person or a small group of people. The second criteria is that the behavior has to be harmful in some way. So, Susan, if I roll my eyes at you, is that harmful to you? Technically, if that's the only thing I do, it's not harmful. It's not harmful unless there's a whole other group of behaviors that I'm also displaying towards you. In particular, in healthcare, what we want to look at is that person's behavior harmful in any way to patients? So, for example, if you're following me and taking over my patient assignment, and I leave out an important piece of information for you to be able to actually care for this patient, setting you up to fail, that's harmful to patients. Okay, so we're looking at harm. And the third criteria that I think is one of the most important is the behavior has to be repeated over time. It can't just be one time I get testy with you in a crisis situation. And what I find doing deep dives in organizations is actually not as much bullying, true bullying as you would think. I find an awful lot of incivility. And, you know, incivility is that sort of lower level. It's the eye rolling. It's the being condescending. It's, you know, those when people say, well, you know, that's just the way it is here. It makes me think that there's a lot of incivility. Now, keep in mind, if you leave incivility unaddressed, if you ignore incivility, it can lead to bullying. But you see, I think, and this topic right now that, you know, on the slide, bullying defined, I think is so incredibly important for our audience to truly understand, because bullying, that's actionable. You usually have policies related to specifically, you know, bullying behavior, but incivility, that's culture. That's a completely different way of addressing. So again, the audience, I hope you truly understand what the difference is between bullying and incivility and everything else.
Okay, thank you, Renee. So that brings us to our first polling question. So of the following behaviors, which behavior have you experienced or witnessed most often in the workplace? Public criticism, yelling, gossip, silent treatment, mocking, and or eye rolling. Renee, what are your experiences with these behaviors?
Well, it'll be interesting to see how the audience responds, because I have surveyed thousands of nurses and physicians and support staff and looking at what are some of the most common, what anyone would consider unprofessional, disruptive, or inappropriate, disrespectful behaviors in the workplace. And these are just a few of them. And if you look at some of these, like I said, public criticism, there's yelling, there's gossip, there's silent treatment, and of course the, mocking people behind their backs or the eye rolling. But let's not, discount things like physical aggression or people threatening each other. I mean, we see those types of behaviors too. Or, people setting each other up to fail, so sabotage, withholding information. Some of those behaviors, though, are a little more difficult to actually capture because they tend to be a little bit more covert, which we'll talk about in a little while.
Okay, so I do see the results here. Most people are answering that gossiping is the main issue, followed by mocking or eye rolling, and public criticism, yelling, and then I have the percentage. I'm sorry, 66% say gossiping is their most often witnessed in the workplace, followed by 16% of mocking and or eye rolling, 9% public criticism, yelling, and 6% of silent treatment.
Interesting, because I will tell you what I have found nationally. The number one behavior, what would be considered disruptive behavior, is yelling, criticizing in patient care areas, even to the point where it's happening in the patient's rooms. But sometimes gossip is part of that. So, I'm actually thankful. It makes me feel better that, people didn't identify public criticism and actually yelling as the top behavior, because that to me is more concerning. But here's what I know. Gossiping was number one, according to the audience. Mocking, number two. This is incivility. This isn't always true bullying. This is more culture. And for me, though, you have to take a step back and look at this. Is if you have an environment where so many people are talking badly about each other behind their backs, that organization needs to take a look at doing a culture shift and saying, what's acceptable, behavior and what's not. Because, again, a lot of this is happening in front of patients.
All right, let's move on to the next slide. And I know you've been talking a lot about this, Renee, but we did try to break down the types of bullying behaviors into the overt and the covert, because, as you're saying, bullying is not just about yelling and screaming between individuals. And often bullying can manifest and that cannot always be seen. And this might include behaviors such as giving a colleague the toughest assignment or loading them with too many patients. So we just wanted to, again, break that down and look at the types of behaviors. And you could see here the overt and the physical and the verbal, and then the covert, which is what you were mentioning, the eye rolling and the gossiping. So can you describe some examples of what you're seeing and what is the impact on the patient?
Sure. I think the easiest way to start really getting clear on what behaviors are occurring that, are inappropriate in the workplace is really to categorize them as, overt or covert. And of course, overt, everybody can see it. Everybody can describe it the same way. And, I like how you actually even further categorize into physical and verbal. We definitely see more overt verbal behavior than physical. But, it's when you take a look at, shoving, pushing, slapping, twisting. I was just with an organization who I got together with their leaders, and they were describing some of the behaviors that they often witness, and a lot of it is slamming. They said people are slamming their clipboards on the counter when they don't get the assignment that they like, or they're throwing things, like you have here, throwing an object, and we've seen this before, throwing pens, throwing, just pieces of equipment. But one of the things that it came up, and it reminded me of my own experiences where sometimes nurses can be very, very territorial. So it's their chair, their computer, their space on the unit. And I had an experience once, and this was shared with me, where a nurse was sitting in this other nurse's chair and working on her computer. And this nurse came over and said, "You're in my chair. You have to get out of my chair." And she's like, "I'm almost finished. Just let me finish this documentation." And this nurse got really adamant about, her getting out of her chair. She's like, "You are in my chair. You need to get out of my chair." 3 times she asked her to get out of her chair, and this nurse was like, "I'm almost done with my documentation." Well, this nurse took it upon herself to take a cup of water and throw it at her. And I thought to myself, what is wrong with people? I mean, this is a professional. And, I was asked, when I shared that, well, is that nurse still there? I said, yes. Why? People said, well, that's just the way she is. You were in her chair. So, we see these overt behaviors, even threatening behaviors. I was a manager years ago, and I actually had one of my nursing assistants threaten one of my nurses. And she basically said, "My boyfriend knows what shuttle you take and is going to be waiting for you, and he's going to, beat the SHIT out of you." Now, not only did my employee say this out loud, but she said it in the hallway in front of my patients' rooms. And how I found out about it was because the wife of one of my patients heard this and was concerned. So when we take a look at these types of behaviors, one might think, well, if it's nurse to nurse or nursing assistant to nursing assistant, how does that impact patients? Imagine being a patient hearing that, hearing these types of behaviors, because I think for some reason we think that there's this invisible force field around the nurse's station and nobody hears us. Think about in an ambulatory care area when the nurse's station is in the same room as all of the patients at times. And, these types of overt behaviors. But I think all of us would agree we would much rather deal and address an overt bully than a covert one, because this is the hardest thing to address, because overt, these are people who are so nice to you, but as soon as you turn around, they're stabbing you in the back. And, it is, sometimes it's the gossiping, spreading rumors. And I like that you included social exclusion, because this is what I know about social exclusion. When people feel that they're on purpose being excluded from the group, the pain center of their brain lights up. So it's physically painful to feel excluded. And I will tell you, Susan, I hear this type of behavior happening all the time, where you've got these cliques and they're getting together and they ignore this other person. And we see this show up a lot too when nurses are in charge making assignments. And so, again, showing favoritism, unfair assignments. They give the good patients to the nurses they like, and not so good patients to the nurses they don't like. So it's just a great way to start down that path of being able to clearly identify the behaviors that are occurring that you believe are disruptive in some way. And then you do a deeper dive to say, okay, is this really bullying or is this incivility?
Okay, thank you. Okay, so we come to another polling question. I think this will be very interesting to see the results, in which we are asking a true or false question, in which you would answer, I have at least one person in my department whose behavior is disruptive. So is there someone in your department who you do find troublesome? And we're asking you to, answer true or false. So do you think, Renee, that this is the norm in healthcare facilities, that there is a disruptive person in a particular department?
Well, it'll be interesting to see how the audience responds, but hands down, everywhere I go, when I ask a question about somebody's behavior as disruptive, I get the same answer. Now, I like the question the way it is. It's disruptive behavior, not necessarily, I have at least one person in my department who's a bully, Because remember, people interpret that, bully in a lot of different ways. And, I've worked with some organizations who want to add a question to an existing survey about bullying. And they'll say, we want to ask them, do I feel I work in a bully-free work zone? And I thought, that's not really well written, because people have a different interpretation of what bullying means. That's why, disruptive, I think everybody gets it, that there's just some way they disrupt the work.
Well, the results are here, and 82% of the people said true, that they do have at least one person in their department who they consider disruptive, and 15% who do not feel that that's the case.
Well, that's actually, maybe that's good that it's not as high as what I've seen out there. In my experience, I've seen about 95% of the people who I've asked, you have one person, who you would consider, a disruptive force on your unit. Yeah, it's at least 95%. So we're a little better here in Pennsylvania. Yay! Okay, only 82%. Maybe that means we're doing our due diligence to, address disruptive behaviors.
Okay, so on the next slide, we're going to just take a few moments in the next 3 slides to review what Kelly and I found when we looked through events reported to Pacers that occurred over a 2-year period from July 2014 through June 2016. And when researching for these reports, in the description, we use keywords. We look for keywords such as belligerent, rude, bully, disruptive, and yelling. And what we found were that 77% of these events involved verbal abuse, such as rude behaviors. Intimidating behaviors, such as badgering, were found in 73% of the events. And then other behaviors included work interference and humiliating and threatening behaviors. And on the next slide, the events were, on the next slide, by event type. Anyway, bullying by event type, we found that the events were categorized in 5 different event types in the taxonomy, and 57% were categorized in other miscellaneous, followed by 27% in error related to procedure treatment tests, just to see how they were categorized in Pacers. And on the last slide, bullying events by care area, the literature indicates that areas of healthcare, such as the operative setting, which we were talking about before, are prime environments for bullying. And this is in part due to the high risk and high consequence of the area of care. And so when things go wrong, the stakes are high, and it leads to very high tension and short fuses. So here we see that this was similar in the Pacers events, and most occurred in the perioperative area, and that was followed by the medical surgical units and then the emergency departments. So, Renee, given this data, are you seeing similarities across the nation and even internationally?
Well, there are some similarities, but I'm noting some differences. So in my experience, what I have found, there are 3 primary areas in an inpatient setting where we see more disruptive behaviors, and that's surgical services, which you've identified here. It's the emergency room, which you've identified here, and it's the intensive care units, so any critical care unit. So it's interesting, you have medical surgical units. I find them to be a little bit lower on this list. And if you look at specialty areas, we look at the NICU, if you have a NICU, and mother-baby. Yeah, those are the other 2 areas. I consider them little subspecialty areas. And if you look at ambulatory care settings, dialysis tends to be up there. And you know what, Susan, I've been giving this a lot of thought. Why are we finding more disruptive behaviors in these areas? And you mentioned it. These are areas that there's more unpredictability, there's more life and death, there's higher stress. And, of course, we can all misbehave when we're in stressful, situations. But in order to maintain your level of competence in those high-stress areas, you really need to be confident in your skills. And I think there's a fine line between confidence and arrogance. And I find that sometimes in those areas, they tend to cross the line a little bit more to the arrogant side. So we see more incivility, we see more bullying and just general disruptive behaviors in those types of areas.
Okay, Kelly. Now I'll turn the program over to you.
Thank you, Susan. Great information so far, and I really like the dialogue here. I think what was difficult with the analysis and looking at what was in the reporting was how do we connect the dots and how do we relate these kinds of reports and what we saw to patient safety. And when we talk about communication and communication being a big component of or root cause of sentinel events, that's huge. And I bet any number of us can remember probably working the first night shift as any clinician and thinking, do I need to make a phone call? Do I need to wake somebody about this issue or that issue? And having one phone call where we may have been berated, it wasn't very nice, the dialogue was not the best, leaves a lasting impression. And how do we use that information moving forward? How do we end up letting that impact the care that we provide? So communication is huge in the team, and teams are a big component of what we're doing in healthcare anymore. Our patients are sicker, transitions of care are more difficult, there's more comorbidities, and that dialogue and communication, we tend to shy away from those experiences or those situations where we might be putting ourselves in the setting of being exposed to those kinds of behaviors. So I think of teamwork and communication as a huge component. Renee, what are some of the things you're seeing? And with any of these points here, how are you seeing those impact patient safety?
Yeah, you're absolutely right, Kelly. When you have, poor communication among the teams, it really impacts patients, and people don't think about it in that way. But, classic situation on an inpatient unit, let's say it's 2 o'clock in the morning, and you're concerned about your patient, but you look on the on-call schedule and you see that who's on call is the physician notoriously known for screaming and yelling at nurses and making them feel like idiots. And you end up saying, I'm not calling him, he's nasty. Well, the new nurse overhears you. And when she's in the same situation 6 months from now, and she will be, she makes the same decision. And so taking a look at not being comfortable communicating with someone, especially a physician when you have concerns about, patients. And there's this whole other conversation we could have about improving the relationship between physicians and nurses. And I've actually worked with some physician groups who have said, we want to improve the relationship. What do we do? And I do some scripting with physicians. So, a lot of times nurses will call and say, I'm so sorry to wake you. I'm so sorry to bother you. Teaching the physicians to say back to that nurse, please don't apologize. If this was my mother, I'd want you to call me, okay? And I step back, and when I work with nurses, I say to them, if that was your mom, even though this physician may scream and yell at you, would you call? Of course they would. Well, this patient is somebody's mom, somebody's dad, okay? So it's having that recognition that we have an ethical responsibility to communicate with each other despite how that person might react. But, another, problem that's very similar to this is when people will say, oh, that's just her personality, or that's just the way he is. He doesn't like people very much, which is bizarre to me that somebody can actually work in healthcare and not like people. But I hear that all the time. And, they'll defend themselves and say, well, I'm not warm and fuzzy. This is just me. This is what I always say back. If people are not comfortable communicating with you, then it's going to stop the flow of information. And when we stop the flow of information, that affects our patients. Not okay. And, you have to be able to go back to people. I don't care, nurse, physician, nursing assistant, housekeeper, whomever it is, to say the way you talk to people in this space needs to be very open. You have to convey a sense of approachability, and you have to treat people with respect, especially when people are trying to communicate with you something about patients. And, just think about it. If you're spending a lot of your time tiptoeing around certain people who you're working with, how does that affect your morale? how does that affect we talk about employee engagement all the time. I'm telling you what, people disengage. And, you have on here, it decreases retention. Absolutely. But, it's interesting because, taking a look at, especially at nurse retention, we've got this generation of nurses that are coming into the workforce now. If they don't feel supported and they don't feel that they have opportunities to grow, they will leave you, okay? And if you don't create a supportive professional environment, they will leave. Well, what if you're an organization that you're the only game in town? I've worked with a lot of organizations that they're it. It's maybe an urban area, a rural area. Well, they don't have a choice. They won't quit, but then they disengage. And sometimes, don't you agree that that's worse? So all of this, affects patients in the end.
So that leads us to our next polling question. And again, this is another true-false. My organization has a process in place to address complaints of disruptive behaviors. And Renee, your thoughts about this, because I think even when I went to different facilities and I would ask, even just related to Joint Commission National Patient Safety Goals, hey, what are you doing related to alarm management? Well, we got a policy in place. Yes, we're taking care of it. Okay, tell me what you're doing. Oh, yeah. I don't know. Is it the same sort of, what are you seeing with facilities out there?
Well, I always ask these questions. What policies do you have in place? Do you have a process? And I look at things from the organizational perspective. So, do you have policies, okay, that are either hospital-based, department-based, system-based? But then that's policy is one thing, but then what's the process? What do I do if I'm a frontline leader and somebody comes into my office and they're telling me that they were treated in a way that's really concerning by one of their coworkers? What do I do? And, oh, gosh, I'm looking at the results right now, and it shows that 80% that they have a process in place. Only 19% said that they do not, which is really interesting because what I find across the United States is that there's not a clear process in place. So I would be interested in talking to the people who say they have a process and whether or not they're following that process. So interesting results.
Just wanted to highlight a little bit, definitely this topic is being discussed at a national level. Not only is Renee seeing things that are going on throughout organizations, but certainly Joint Commission has information out there. And you can easily reference the Joint Commission's website and look to this material, but recognize that the Sentinel Vent Alert came out 2008, and then there was communication again back just in June of 2016 related to this topic, and even referencing their leadership standards. So information and recommendations about education, policy, and procedure, developing the process to address these behaviors. Also, ANA has the same sort of information out there referencing their position statement and talking about a commitment as an organization to creating an environment that is trustworthy and safe, encouraging reporting of violent sort of events. Some of the more boots on the ground recommendations, becoming familiar with the policies that are in your organization and how to address those when you're in the moment. So Renee, what are you thinking about what some of these national leaders are saying and doing?
Yeah, it's really nice to actually see, especially the professional nursing organizations stepping up and making an attempt to identify and address workplace bullying and incivility, because we know of its impact to patient care and the nursing profession. I mean, we are hemorrhaging really great nurses to this problem and can no longer afford to use silence as a strategy, because that's what we've been doing for decades. And it's interesting, something new that has come out, the magnet designated organizations to be receive magnet status and to continue with magnet status, they've added addressing workplace bullying and incivility as one of their requirements. So it's really nice to see these organizations stepping up and saying, not okay. We used to, shush, shush, hide it under the rug and, let's not talk about it because, nurses are the most ethical profession. We're trustworthy. Oh, my gosh, but yet we're cruel to each other. We don't want that out. I've actually done some work in organizations that they tell me, okay, we want you to come in, to do a workshop or do something on your bullying and incivility. Just don't use the word bullying. I'm like, are you serious? Let's talk about it. And that's exactly what these organizations are doing, is saying, we have to be transparent here. The way we treat each other affects patients, and we're in the service industry and have that ethical responsibility to serve our patients in a way that reflects who we are as a profession. So, yeah, it's really nice, Kelly, to see that they're stepping up.
A little question that I know we had talked about this prior in preparing for this session. A lot of literature out there is related to nursing, and that is where a lot of the dialogue ends up. But we kind of talked about, well, what's going on in other departments, because we recognize and know this isn't just about nursing. What are you hearing?
Oh, yes. Here's I'll just give you the 1 minute version. Here's the deal. We usually start with the nursing department in an organization because that's the highest population, and there's more nurses than any other role. But I'm telling you what, if you have human beings working in your organization, the same rules apply or should apply to them. So what we usually do is start with nursing and then scale this work to other departments, so respiratory, physicians, support staff, ancillary staff, all the way across the organization, because we don't work in silos, although sometimes we act like we do. Think about any department, inpatient or outpatient. You have nurses, physicians, you have techs, you have therapists, you have a variety of employees. You have housekeeping, you have dietary. The way we treat everybody reflects how the care we give to our patients. So, yeah, absolutely, it should be scaled across the entire organization, any efforts to improve the work environment.
Thank you, Renee. Moving to the strategies, and I think this is probably what everybody's waiting for. Okay, so what do we do about this? I think it's kind of interesting just recognizing that disruptive behavior and how even the frontline staff Susan and I were presenting somewhere, and we had an individual come up and speak to us, and they were kind of chuckling and laughing, ha, 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 I am the bully in our unit. Mm-hmm. Oh, my, okay, we recognize that, but now what? So what are some of the strategies that are out there for the healthcare workers at the front line?
Sure. Well, one of the reasons that bullying continues and incivility continues in healthcare is because we have accepted it as the norm. Well, that's just the way she is. That's just the way, he is. Don't take it personally. And so we really need to take a step back and heighten that sense of awareness to help people to recognize that these behaviors are really disruptive, inappropriate, unprofessional, and should never be here, okay? And so once people can recognize that way, the way you just treated me is not okay, then we can work with people on how to speak up in a way that's respectful, that's honest and respectful. And, that's when you're on the receiving end of disruptive behavior. But what if you're witness to it? I find that more people are silent when they witness bad behavior than when they're actually experiencing it. And so we know one of the most powerful interventions to stop the cycle of bullying is for the witness to speak up and intervene on behalf of that target. When I do workshops, it's amazing to me. The number one most common comment people make is that they're going to become more aware of their own behaviors and adapt their own behaviors. Because like you said, sometimes we're the ones who are part of the problem. The bully can't be everybody else. So it's taking that mirror and turning it back on ourselves to see how we may contribute to an unprofessional work environment. And then I think it's important that we give people confronting techniques. So these are, I think, some, things that I've shared with you, and I share them everywhere I go. How to use scripting. And I know that that's something that you do too, is giving people scripting techniques and saying simple things like, I'm offended by that comment. Or, I'm not sure you're aware of this, but sometimes you can come across as being a little intimidating, and then give an example. So, because I think for many of us, when confronted with bad behavior, you can't think in the moment. But, the next day in the shower, you can think of all sorts of things to say. So scripting techniques and planning ahead of time can be very helpful. And sometimes just naming the behavior. You're yelling at me in front of people. You're criticizing me in front of a patient. Not okay. Or, the way, you're gossiping, not here, not now. So I think, and using the assertive style, being honest and respectful with people can be very helpful. And, of course, document. But, it's documenting in a way that helps your organization to take action. So, things like date, time, location, if there are any witnesses, use verbatim comments. And then I think one of the most important things with documentation is to make sure you're clearly linking that person's behavior to a patient safety concern or a violation of your policy. So those are just some tips for, healthcare employees to be able to address workplace bullying.
And I will put a comment in here right now, just that we do at the end, towards the end here, have some of the resources that we have on our website. So we encourage you to look to those because, as Renee indicated, that self-assessment tool that she has shared with us, I recall looking over that and thinking, oh my gosh, did I do this? Oh my goodness, what about that behavior? And it's really that. Doing that self-reflection is really imperative, I think, for all of us to even look at our own behaviors.
Yep. So, I agree.
Taking us to the next polling question. Again, if you do not see it, click on the icon in the upper right-hand corner. But my organizations provide leaders with initial and ongoing skill development related to how to address bullying and incivility, true or false?
Yeah, again, it will be interesting to see how people respond because I think in general we don't do a good job equipping frontline leaders with the skills that they need to be able to set behavioral expectations and hold people accountable. So I know that across the country, I'm not seeing a lot of efforts. And here we go with the polling. 65% said false, so the majority said false. I actually, Kelly, have never worked with an organization that actually had content related specifically to bullying and incivility in any of their leadership development. Nothing. So it's a problem because we know it's the frontline leader who is ultimately responsible for cultivating a culture of professionalism and, addressing workplace bullying. So, yep, that validates that we need to do a better job. And, this slide on strategies for managers, it's all about being able to recognize bullying and incivility yourself, and that goes back to clearly understanding what bullying is and what it is not, and really getting together with your team and co-creating a set of behavioral expectations. And I do an activity that basically starts with, how do we always want to be treated by each other here in this space? How do we never want to be treated by each other? And you get everybody to contribute to that, and that forms a, unit-based or department-based behavioral expectation. And then, it's this ongoing, I call it my drip campaign. You can't just send everybody to a workshop or just read an article and check a checkbox and say, oh, yeah, now we know how to address these issues. It has to be ongoing. And then especially for leaders to partner with their human resource representatives, because I find that there's a huge disconnect there where the managers say, I go to the HR rep and, they're telling me that, I didn't do my due diligence. I didn't counsel them enough. I didn't dot my I's. I didn't cross my T's. But then I talk to HR and they'll say, I've never heard about this employee. Yet this is the first time they're coming to me and they're telling me they want me to approve a termination. And I look at their performance reviews, and for the last 10 years, they've met or exceeded expectations. But they want me to approve a termination. So we need to do a better job strengthening those relationships and ultimately, having the policies in place that support that and holding people accountable.
And that brings us to the organization as kind of a whole and overarching strategies. And what are you seeing across the country?
Yeah, I think, declaring that professional conduct is important is a top priority. I read an article not too long ago that said only 6% of all healthcare leaders have identified workplace bullying and incivility as a top priority, but I think it was like 90% said it was a problem. I'm like, whoa, if you've identified that it's a problem, it needs to be a top priority. So it's declaring this is a priority for us and making sure that at the organization level you have that hardwire, ongoing education and training. And then, that's to include content in your existing curriculum. And then I think it's critically important to establish that process for addressing disruptive behaviors. And although the audience said that they had one, I'd really like to take a look at how they're utilizing that process and if everybody's being consistent with it. And again, making sure your policies are clearly defined, workplace bullying and incivility.
And we shared some stories from the reporting system so that you can see what has been reported through the PACER system. And I'm not going to read through word for word, but recognizing individuals yelling at one another during a shift and how dare I question her about information. The next one about somebody being hung up when trying to get more information and obtain a consent, being told that it would be the nurse's fault if the patient dies, being hung up on over the phone by an individual. And then the last one that we shared, when trying to get re-signing of a consent, kind of getting that aggressive attitude and or reaction and signing on the witness line and stating there you have your witness. So those are some of the scenarios that we shared from the reporting system. I also want to reference you talked about scripting. We developed a little handout, kind of business card size, and this is not the front, this is the front side. The back side has the scripting using the desk tool from Team Steps. That way somebody can ideally keep this on yourself, and then if you get in that situation, not that you're necessarily going to pull that card out, but here are some things that you might want to say during those situations. Finally, the resources that we commented about, and some of Renee's tools are on here. Again, what if that bully is you? Doing that self-assessment and looking kind of at your own behaviors and where you fall. So these are all available on our website. And then you can see our references. At this time, Rick, I'll turn the program back to you.
Wow, thanks, Kelly, Renee, and Susan. You've really provided a great deal of valuable information. We hope everyone attending today's webinar can find useful in their organization. So that concludes our slide presentation portion of our program. Now we would like to begin our question and answer period. First question is, please address bullying from patient/family, resident family members, for example. How prevalent is this acute and or long-term care? Thank you. So.
Yeah, well, let me tell you, it's probably when I look at the trends that are happening, and I've been doing this work for probably about 8 years now, over the last year, every single workshop I do, every single, intervention I'm doing with a hospital or ambulatory care center, that question is coming up. It never came up before. I'm telling you, it's just been in this last year that people want help to address patient and family disruptive behaviors. And what I will tell you in the few minutes, that I have to answer this question, this needs to be an organizational, priority where you take a look at, as an organization and say, all right, patient satisfaction is important. We all know about HCAHPS, but how are we going to handle disruptive behavior by patients and family members? And there's a couple of things. Actually, I've done some presentations on this where you take a look at setting clear expectations with patients and their family members. And I do a lot of, wordplay and scripting. So, for example, let's say you have an employee who's caring for a patient and the patient is cursing and really using, a lot of profanity and screaming and yelling at the nurse. And maybe it's the family member. You teach that employee to say things like, you know what, I am willing to care for you, to provide, whatever I need to provide, all those things, whatever it is, that person is doing, as long as you're willing to treat me with respect and not use profanity. So I'm not going to take care of you if you're not, going to be nice to me. No, I am willing to do my part, basically, and care for you as long as you are willing to be respectful in how you talk to me. But here's the key, is that you have to have the organization who supports the nurse or any employee for actually having that conversation and saying, we're not willing to care for you anymore. There's actually, I read this not too long ago, there's a physician, rights that as a physician, they have a right to be treated with respect by their patients. Every organization needs to do the same thing with their employees, that as the employees here, we have a right to be treated with respect by our patients and our families. Big topic right now, hot topic.
Yeah, typically sometimes organizations forget they have the patient's rights and responsibilities, and the patient has the responsibility of conducting themselves in an appropriate manner. We do have a similar question, which I think you've already answered. We currently have a situation where nursing staff are being bullied by family. How do you address this? So I think that what you just said kind of addresses that question as well. It's something that's very concerning to organizations, especially based on the couple of questions that we've received so far.
Sure, and something else.
Renee, I would ask of the role playing. Are you seeing a lot of organizations doing that? I read an article prior that talks about providing the scripting and doing role playing, and in that it prepared individuals for those, not that it made it any less difficult to have the conversation, but they felt more prepared to handle those kinds of situations. And are you seeing facilities utilizing that methodology?
Not as often as I think they could, but just like with the scripting, it's here's the situation, how would you handle it, and then give people the scripts and then have them practice, I think is very powerful. So what I always like to do, because it's always interesting, and when you give people options, so you say, okay, here's the situation, you get them into a group, then you say, how would you handle this? And then get them to come up with how they would handle it, and then as the facilitator, then it's an opportunity for you to redirect, because a lot of times the way they're going to handle it isn't really the best way of handling it, but to let them think it through themselves first. But then, yes, give them the tools, give them the scripts and say, okay, let's think of a situation, that you commonly find. Here are some ways that you can handle it. Because, and this is what I think, too, about, especially when families are disruptive, everybody has a story. Everybody, I think about my own kids, they were sick once and really, really sick in the hospital. I was a different person. I'm like the mother bear, and those are my cubs, okay? And so we have to at least take a step back and do our due diligence to reach out to that family member and say, I can only imagine what it would be like. Do you want to talk about it? Okay. I think we get so caught up in our tasking and running in and running out and doing all these things that we forget that that's somebody, that patient is somebody who that family member would die for, at times. And so coming from that place of I want to help you, I want to understand you, but I'm not going to, take your abuse kind of a thing. You know what I mean? So it's got to be both ways.
Okay, maybe the panel, you can address a comment that was made by one of the attendees. I'm wondering if they wrote, I'm wondering if we are able or will see an uptick in people speaking up against bullying behavior due to the current changes in society's culture, women speaking up against sexual misconduct. Organizations can afford to not address these behaviors, cannot afford to address these behaviors. Do you anticipate that type of a uptick?
I do, and it's funny because I'm working on writing an article about all of this, the Me Too, campaign and what's happening out there, and sort of relating it in some way to bullying. The only thing that I'll say is, for years, employers have a responsibility, a legal responsibility to actually protect their employees from any type of abuse. And employers have not done a good job in general, as a general statement, being able to do that. However, now that people are starting to speak up about it, they're starting to actually hold employers more accountable now. my only concern with this, emphasis and focus on especially sexual harassment, that we're going to blur the lines again. Because remember, there is a legal definition for harassment. There's not a legal definition for bullying. And so I'm just hoping organizations will make sure that they clearly define all of them from, the organization, and then respond accordingly. But yeah, I think now's the time to take a look at your policies and your process and make sure that you're ready to go, because you may need it.
How do you correct a tenured nurse with disruptive behavior that has been overlooked or brushed under the rug for an extended period of time?
Oh my gosh, I just wrote an article that came out on Tuesday. It's how do you tell your quote unquote best nurse that she's toxic, okay? Because it happens all the time. There's been a nurse who's been working for decades and who is the essential, queen bully on the unit, but yet nobody's ever done anything about it. Nobody's ever addressed her. So I actually wrote an article about this. It's about sitting down with that person, whoever it is, and having an honest conversation with them. Like, look, you're very clinically competent. When you're caring for patients, I know they're going to get the best care, but you're not very nice to people, and that's not okay. And, we're going to have a conversation about what my expectations are of you moving forward starting today. And, there's a whole list of other things you need to do to prepare for that conversation. But the key is we're not having those conversations. We're justifying, rationalizing, ignoring, that toxic person because they happen to be clinically competent. And that's what we see a lot. But, I forget the Chinese proverb that said, when was the best time to plant a tree? 20 years ago. When's the next best time? Now. So if nobody's addressed her behavior or his behavior for 30 years, now's the best time. Okay? If nobody's done it before, start now. And, getting examples and being very clear on what your expectations of that person moving forward, that's critically important. But please start having conversations with these people because they think they're untouchable, and then that makes them even more arrogant and, it makes their behaviors exaggerated. They get on this power trip now because nobody's ever addressed them before. I could talk probably for another hour just about that topic, okay?
Again, thank you so much, Susan, Kelly, for your input, and especially to our guest speaker. I can't say enough about the information that you provided and how helpful it's been to the organization that are participating in today's webinar. So, again, thank you to Dr. Renee Thompson. And I'd like to say that with that note, I'm going to be concluding today's webinar. Thank you all.